My name is Roger Henderson. I'm a GP in southwest Scotland, and I also co-host the GP Notebook study groups. Welcome again to this GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now, you can find us on all major podcast platforms, including Spotify, Apple Podcasts, and Google Podcasts. So do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups, and you can also visit GPnotebook.com for podcast episode show notes and to find out more about the upcoming study group meetings which occur all year round. Now, in this episode, I'm going to be discussing Roseola. And Roseola infantum is a viral infection that primarily affects infants and young children, most commonly between the ages of 6 to 12 months. And the main culprit behind this illness is human herpes virus 6, HHV6B, though in some cases, human herpes virus 7 can also be responsible. Now, HHV6B is found worldwide, and over 90% of children are seropositive for it by 24 months of age. Primary infection with HHV7 occurs at an older age than HHV6, and about 65% of children are seropositive for HHV7 by 36 months of age. But by adulthood, over 95% of patients are seropositive for HHV6, with 85% being seropositive for HHV7. Now, there are 3 species of the human herpes virus in the Roseola virus genus. We have HHV6A, which is actually associated with thyroiditis. We have HHV6B, Roseola, and HHV7, also Roseola. Now, some of you may remember that historically, Roseola was classified as the 6th of the 6 classic childhood exanthems, hence its name, 6th disease, following measles, scarlet fever, rubella, Duke's disease, and erythema infectiosum. Roseola is found worldwide and accounts for up to 10 to 45% of febrile illnesses in infants, with the virus being primarily spread through saliva and respiratory droplets, making it highly contagious among young children. Studies show that 40% of children are infected by 12 months and 77% by 24 months of age. Interestingly, Roseola tends to peak in the spring and autumn seasons, although cases can occur year-round. And once infected, a child develops immunity to Roseola, actually making reinfections rare. However, HHV6 can remain latent in immune cells and has been known to reactivate in some immunocompromised individuals, and this can lead to complications such as encephalitis or bone marrow suppression. Now, we usually diagnose Roseola on the classic presentation of a previously healthy infant, usually 6 to 24 months age, with the sudden onset of a high fever. This can be as high as 104 degrees for 3 to 7 days. And about 15% or so of children may actually present with a febrile seizure as a result. Now, during this time, the child actually usually appears relatively well, although there may be minor irritability, some mild congestion, conjunctivitis, or loss of appetite. And occasionally other symptoms can include a runny nose, swollen lymph nodes, and mild diarrhea, classic viral symptoms. There may also on occasions be tympanic inflammation, some periorbital edema. You can sometimes get a bulging anterior fontanelle, lymphadenopathy, and abdominal pain. Now, this high fever often then reduces, but in its place, the typical exanthema of roseola appears 3 to 5 days after the onset of the illness. And this consists of the classic pink-red macules and papules on the trunk, neck, and proximal extremities, occasionally on the face, and lasts for about 1 to 2 days before fading away. Now, an important point here is that unlike rashes from other illnesses such as measles or rubella, the roseola rash is not itchy and does not cause discomfort. And so diagnosing roseola is almost always clinical. And for patients with a classic presentation, a clinical diagnosis can be made simply on physical examination, findings, and history, usually at the time of the loss of fever typically. We rarely perform serology, and it's usually only needed in children with complicating factors such as encephalitis. Now, the other illnesses that can often mimic roseola do include measles, but roseola doesn't have the cough, the conjunctivitis, or the Koplik spots that are associated with measles. Rubella has a rash that appears at the same time as the fever rather than afterwards. Scarlet fever, which is caused by a bacterial infection, involves a sandpaper-like rash, unlike roseola. And drug reactions also can cause widespread rashes rather than the typical roseola rash. And so, as I say, one key differentiator is that in roseola, the rash appears after the fever breaks, whereas in many other viral rashes, the rash and the fever usually occur together. Now, if we look at treatment, there is no specific treatment we usually need for roseola, and in general, symptomatic control is the mainstay of therapy here, and this includes antipyretics and the maintenance of oral hydration. And paracetamol and ibuprofen can be given, and we allow the child to rest as needed, but obviously we avoid aspirin because of the risk of Ray's syndrome. Now, there's currently no roseola vaccine, so the best prevention is good hand hygiene and avoiding exposure to sick children. Now, the vast majority of cases resolve without issue, but primary HHV6 infection has been linked to certain complications, including myocarditis, hepatitis, and even Guillain-Barré syndrome. But the most important one here, I suppose, is febrile seizures, as up to approximately 1/3 of first-time childhood febrile seizures may be attributed to primary HHV6 infection. Now, fortunately, the majority of isolated febrile fits in otherwise healthy children do not require treatment or further workup. But personally, I would always recommend consultation with a pediatrician in each case of first febrile fit. Emergency evaluation is recommended in the setting of more than one seizure episodes lasting more than 15 minutes, or seizures in conjunction with any other complicated factors. Now, if we have an immunocompromised individual, HHV6 can cause more serious issues, but fortunately in healthy children, as I say, complications are rare. Herpes virus antiviral drugs have been used to treat HHV6 infection in patients who are immunocompromised and in infants with severe encephalitis, although I have to say their efficacy has not been extensively evaluated in clinical trials. Now, fortunately for all of us, the prognosis for roseola is excellent. Most children recover fully within a week with no lasting effects, and there is very little risk of recurrence in healthy individuals. Following a primary infection, the virus does become latent in peripheral blood mononuclear cells, and reactivation after solid organ or bone marrow transplantation has been associated with morbidity. So that was a quick overview of roseola, and I do hope you found it helpful. But do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email support@GPnotebook.com if you have any questions, comments, or ideas for future podcasts. We really do enjoy hearing from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and to download free shortcuts to help improve the lives of our patients in primary care. But as always, until the next time, thank you for listening and goodbye.